Let's discuss back pain treatment. First, let's define acute pain. Acute pain is pain that lasts less than 12 weeks. More than 85% of back pain cases will fully recover, especially when the pain does not radiate to the leg. Most cases are mechanical, meaning the pain worsens with movement and improves with rest. Initially, we should rule out infection, cancer, or trauma, which require urgent treatment. If there are no serious risk factors, imaging tests are generally not needed within the first month. Low back pain has a high recurrence rate. Almost 70% of people will experience back pain again within the first year. Overtreatment is not required for back pain. Prolonged bed rest should be avoided as it doesn't accelerate recovery and may delay it. Early, gentle resumption of daily activities is beneficial, but vigorous exercise should be avoided in the early stages. Heat applications like heating pads and blankets provide temporary relief for many people. Non-steroidal anti-inflammatory drugs and NSAIDs are used as first-line treatment, but they should be used cautiously in people with kidney, liver, and gastrointestinal diseases. A safer alternative is acetaminophen, although it lacks anti-inflammatory action and is weaker. Ibuprofen is commonly used and is among the safest NSAIDs, but it may increase the risk of bleeding in people with gastric ulcers and can raise blood pressure in some individuals. Naproxen has a longer lasting effect and requires fewer doses per day, but has side effects similar to ibuprofen. Aspirin is also effective but has the highest risk of gastrointestinal bleeding among the options. Celecoxib is a more selective cyclooxygenase 2 inhibitor, often used long-term with the lowest risk of bleeding and ulcers compared to other NSAIDs. Since cyclooxygenase 2 is not involved in gastrointestinal protection, celecoxib is generally safer for the stomach, though it is more expensive and still carries a low risk of bleeding and cardiovascular risks. Diclofenac is known for its strong anti-inflammatory action and quick pain relief, but it carries higher risks of bleeding and cardiovascular side effects. Diclofenac is also available as topical gels that can be applied directly to the painful area, reducing systemic side effects, though it is not effective for deep muscle pains. Generally, these non-steroidal anti-inflammatory drugs are used for 3 to 5 days. Muscle relaxants, such as cyclobenzaprine and methocarbamol, can also be used to reduce muscle spasms, but they may cause sedation and are best taken at night, especially if back pain interferes with sleep. Opioids like tramadol are not first-line treatments and are reserved for severe and unresponsive cases. Opioids should be used for only 3 to 7 days to avoid the risk of dependency. Treatments for acute low back pain have no strong evidence supporting their effectiveness, such as oral or injected glucocorticoids, antiepileptics, antidepressants, and herbal therapies. The same holds true for non-pharmacological treatments. Then now let's discuss treatment for chronic low back pain that is not caused by radiculopathy or herniation. Such pain lasts more than 12 weeks. The main risk factors include obesity, female gender, older age, high stress, poor health, and low physical activity. This common issue with low back pain is overtreatment with antidepressants, injections, lumbar support, or tractions, many of which are not supported by guidelines. More importantly, exercise programs and addressing depression are often. Exercise program is the mainstay for chronic low back pain treatment. It helps reduce pain and improve functionality. Examples of exercises include core strengthening exercises, which strengthen muscles around the spine and abdomen. For managing chronic low back pain, exercise therapy is crucial. Here are some effective exercises. Plank is one of the most important. Start in a push-up position, then hold your body straight with forearms on the ground, elbows under shoulders. Hold for 15 to 30 seconds, gradual working up to longer holds. Bear dog, kneel on all fours, then extend your right arm forward and left leg back. Hold for a few seconds, then switch sides. Like on your back, lift your legs and arms. Slowly lower one leg and the opposite arm toward the ground, then return to the starting position and switch. Other helpful exercises include child's pose, knee to chest stretch, and cat-cow. Gradually increase aerobic exercises such as walking, swimming, pulling exercises, and cycling to build endurance without excessive impact on the spine. Medications like acetaminophen can be used as a short course. Additionally, duloxetine at 60 mg daily is approved, especially if there is accompanying depression. Tricyclic antidepressants like amitriptyline can also be used, as they increase serotonin and norepinephrine levels in the brain, with norepinephrine helping to decrease pain sensation. Injections into the epidural space or facet joint can be used, but they do not show effectiveness for the long term unless radiculopathy is present. Let's discuss the treatment of pain with radiculopathy. Radiculopathy occurs when a herniated disc compresses a nerve root, causing pain that radiates down the leg. This type of pain is also called sciatica. In most patients, condition improvement happens within a few months. It's in approximately 70% of cases. The herniated part will regress naturally over 6 months. Bed rest is ineffective here as well. Patients should continue normal activities. Acetaminophen and non-steroidal anti-inflammatory drugs and NSAIDs can be used for pain relief. Opioids may be prescribed short-term in emergency situations. Epidural glucocorticoid injections such as methylprednisolone or dexamethasone are often temporarily effective. High-dose, short-term oral glucocorticoids like methylprednisolone may also be used. Nerve root blocks are injections of an anesthetic or anti-inflammatory steroid near a specific nerve root in the spine and serve diagnostic and therapeutic purposes. Corticosteroids like dexamethasone or triamcinolone can decrease pain for several days or weeks. These injections are usually administered to the LY4 to S1 nerve roots, also known as the sciatic nerve roots. Surgery is necessary if there is spinal cord compression or cauda equina syndrome, which presents with symptoms such as bowel or bladder dysfunction, numbness in the inner thigh and groin, sensory loss on the trunk, bilateral leg weakness, or muscle stiffness. Surgery is generally recommended if severe radicular pain persists and does not respond to treatment for at least 6 to 8 weeks. For patients who do not improve with conservative treatments, studies show that surgery offers faster pain relief compared to non-surgical approaches. However, after several months, long-term outcomes are similar between surgical and non-surgical treatments.